Good afternoon, guys. I have discussion B for you. Now, for B, we are discussing brain altering sedatives, things that are being prescribed to older adults with consequences of big, big consequences, causing falls, causing sedatives, causing them delirium, causing them issues about getting around. So here we go for B. Please enjoy. These brain altering meds linked to falls and confusion are being prescribed to 25% of older adults with dementia. Every year, clinicians and caregivers face wrenching choices. When older adults with dementia become agitated, anxious, uh, sleepless, or aggressive, the impulse to reach for a pill that promises rapid relief is understandable. Families are exhausted, staff are stretched thin, and acute behaviors can be dangerous. But a growing body of evidence and a recent national analysis show that the medications most often used in these moments are themselves a major source of harm. Central nervous system, CNS active drugs such as benzodiazepines, non-benzodiazepine, hypnotics, Z drugs, that's for sleep, guys, antipsychotics, barbiturates, and strongly anticholinergic antidepressants are being prescribed to roughly 1 in 4 adults with dementia. These drugs increase confusion, slow reaction times, destabilizing balance, and raising the risk of falls, hospitalizations, and even death. The prevalence of such prescribing represents a persistent, preventable threat to the safety and dignity of people living with dementia. What the numbers show and why they matter. A recent analysis of Medicare beneficiaries spanning 2013 to 2021 found that about 25% of older adults with dementia receive at least one CNS active medication. By contrast, prescribing rates were lower among older adults with normal cognition, about 17%, and those with mild cognitive impairment, about 22%, although overall use of these medications declined modestly in the general older population during the study period. The decline did not meaningfully reach people with dementia. Equally alarming, more than two-thirds of these prescriptions lacked a documented clinical indication in the medical record. Why does this matter? Dementia is not merely a memory disorder. It is a syndrome that impairs attention, judgment, gait, and the brain's ability to compensate for physiological stressors. CNS active drugs compound these vulnerabilities. Sedation and anticholinergic effects worsen confusion and can precipitate delirium, slowed reflexes, and impaired coordination. Increased fall risk. Antipsychotics, in particular, have been associated with higher mortality in dementia when medications are prescribed without clear indication, time limited goals, or monitoring plans. The balance of benefit to harm tilts sharply toward harm. These are drugs. How these drugs affect the aging brain and body. The older body handles drugs differently. Age-related changes in liver and kidney function alter drug metabolism and clearance. Body composition shifts. Less lean mass, more fat. Change how drugs distribute and persist. The aging brain has reduced neurotransmitter receives and altered receptors or receptor sensitivity. Dementia magnifies these changes. Cholinergic defects make anticholinergic drugs especially disruptive. Impaired attention and executive function make sedative effects more dangerous. Benzodiazepines and Z drugs. These agents depress central nervous system activity, producing sedation, impaired coordination, and memory problems. In older adults, they are linked to falls, fractures, and cognitive decline. Antipsychotics, often used off-label for agitation or psychosis, in dementia. Antipsychotics carry boxed warnings about increased mortality in elderly patients with dementia related psychosis. They also raise the risk of stroke, metabolic effects, and extra pyram, pyramid, pyramidal syndromes. Anticholinergic antidepressants and other anticholinergic agents. These drugs block acetylcholine, a neurotransmitter crucial for memory and attention in people with dementia. Anticholinergic burden correlates with worse cognition and higher delirium risk. Barbiturates and other sedatives. Less commonly used today, these drugs have narrow therapeutic windows and potent sedatives effect that can precipitate respiratory depression and falls. The cumulative effect of multiple CNS active medications polypharmacy is often greater than the sum of its parts. Even moderate anticholinergic burden combined with intermittent benzodiazepine use can produce profound functional decline. Why clinicians still prescribe them? Several forces drive continued use of high risk CNS drugs in dementia care. Behavioral urgency, acute agitation, or aggression can threaten safety in crisis moments. Medication may seem like the fastest way to restore calm. Limited access to non-pharmacological resources. Evidence-based behavioral interventions requires trained staff, time, and environmental supports that many facilities and families lack. Clinical criteria in the hospital may be continued at discharge without perverse incentives and system constraints. Short staffing, productivity pressures, and reimbursement structures can favor quick pharmacological fixes over time intensive behavior care. These drivers are not excused, but explanations that point to where interventions must be targeted. Training staff, system redesign, and accountability. The human cost of the human cost, falls, delirium, hospitalization, and loss of independence. The the harms associated with CNS active prescribing are tangible and often catastrophic. Falls are the leading cause of injury and death in older adults. Sedatives and anticholinergic drugs substantially increase fall risk, delirium, and acute fluctuating disturbances in attention and awareness. Is frequently precipitated by sedatives and anticholinergic medications and is associated with prolonged hospitalization, altered cognitive decline, and higher mortality. Antipsychotic use in dementia has been linked to increased risk of stroke and death beyond clinical outcomes. These medications can erode quality of life. Blunted effect, reduced engagement, and loss of autonomy are common when people are sedated or cognitively dulled. For families, the consequences are wrenching. Caregivers may feel compelled to accept medications to keep a loved one safe or preserve their own ability to provide care. Yet the medications intended to help can shorten independence and increase the caregiver burden when complications arise. Evidence based alternatives and safer approaches, reducing reliance on high risk CNS drugs, does not mean abandoning symptom management. It means shifting to safer, evidence based strategies that prioritize person centered care. Non pharmacological interventions are first line for agitation, insomnia, and anxiety in dementia. These include behavioral and environmental strategies, structured routines, meaningful activities, sensory modulation, music, aromatherapy, and environmental modifications. Lighting, noise reduction, caregiver training and support, teaching de escalation technique, continuation of medications. This is is a critical skill. Tapering schedules, close up, close follow up, and contingency plans for symptom reoccurrence, may make deprescribing safe and effective. System and policy levers to change practice. Addressing this problem requires action at multiple levels. Clinical practice, mandate routine medication reviews for people with dementia, require documentation of indication and discontinuation plans for CNS active drugs, and integrate pharmacist-led reviews into care teams. Training and workforce, invest in geriatric and dementia specific training. For prescribers, nurses, and caregivers, expand access to behavioral specialists and dementia care coordinators. Payment reform, align incentives to reward non-pharmacologic care and deprescribing activities. Fund programs that subsidize staffing and training in long-term care settings. Quality measurement and transparency. Publicity uh, publicity reports. Facility level rates of CNS active prescribing in dementia care and related outcomes, falls, delirium, hospitalization. Use these metrics in accreditation and reimbursement decisions. Okay, guys, that is your B for you. I won't be back on after a small break with C. Until then, Gator Wellness. Take care, folks.